Good morning, everyone. I'm Wendy Spearman. I'm going to be giving you an overview of steatotic liver disease and the role of food insecurity and alcohol in MASLD. So the Multi-Society Delphi Consensus Statement was published in 2023, and this actually presented the new fatty liver disease nomenclature. It was decided that steatotic liver disease would be the overall arching term, and that was composed of MASLD, MET-ALD, alcohol-associated liver disease, specific etiologies, and cryptogenic SLD. So SLD is diagnosed either histologically or by imaging. And if we look at MASLD, this is defined as the presence of hepatic steatosis in conjunction with one cardiometabolic risk factors and no other discernible cause. The important new entity is MET-ALD, and this is MASLD associated with an increased alcohol intake. So more than between 20 to 50 grams per day for women and between 30 to 60 grams a day for men. And importantly, if we look at this, there's actually a continuum across the spectrum between MASLD and ALD, and within an individual, sometimes the MASLD might be predominant in the beginning, and with increasing alcohol becomes more prominent, or the other way around. Importantly, now multiple etiologies of steatosis can exist. So you can have MASLD plus autoimmune hepatitis or viral hepatitis, and this is what we often see clinically. So the ASLD and EASL guidelines are really quite pragmatic, and they really aim to increase our awareness and ability to diagnose MASLD, particularly at primary health care, and actually advise us on how we need to up-refer patients with more complicated MASLD, MASH, and fibrosis. So you decide whether somebody has steatotic liver disease, either by imaging or biopsy, and then importantly, do they have any cardiometabolic criteria? And so if you only need 1 out of 5, and this looks at BMI, waist circumference, fasting serum glucose, blood pressure, plasma triglycerides, and plasma HDL. And if you're on any treatment for any one of these cardiometabolic risk factors. Importantly, pediatric criteria also exists, also 1 out of 5, but obviously the cutoffs for these individual components is different from adults. And then you really decide, what is the alcohol intake of the individuals? And so if it's less than 20 grams per day and 30 grams per day, that's MASLD, and then you decide, does the individual has MASH, so active inflammation. If it's between 20 grams, greater than 20, but less than 50, and greater than 30, but less than 50 in men, then this individual has MET-ALD. And once it's above more than 50 and more than 60 grams per day in men, these patients have alcohol-related liver disease. But always remember the other potential causes. If you don't have cardiometabolic risk factors, you don't have significant alcohol, things like drug-induced liver disease, Wilson's disease, and then that entity of cryptogenic steatotic liver disease. And really over time, many of these patients will progress to MASLD. So the guidelines are not prescriptive in how you diagnose steatosis. In terms of histology, it's more than 5% macrovesicular steatosis. In terms of imaging, the ultrasound is not routinely recommended due to low sensitivity and specificity. In fact, you need more than 30% steatosis to pick this up on ultrasound. Transelastography, the CAP score greater than 288. The MRI PDFF of greater than 5.5, and ultrasound attenuation imaging of 0.66. But importantly, one needs to assess fibrosis using the non-invasive test, so the FIB4, a low risk being less than 1.3, and these can stay in primary healthcare, and high risk of the FIB4s greater than 2.67. These really need up referral for more and further investigations and management. And if you have access to the transelastography, a warning sign is a KPA greater than 8. But I think very importantly, when you're engaging with your patient, is actually to try and really establish how much they're drinking. Understand that different glasses, different standards of drinks have different amounts of alcohol. And so one needs to actually find out, do you drink red wine, white wine, spirits, or beer, and how much do you take? And really try and establish an accurate volume of alcohol that's taken per day or over a week. So we look at the spectrum of MASLD. We all know this very well, from simple steatosis to MASH, where you have lobular inflammation, hepatocyte ballooning and necrosis, cirrhosis, and then the complications of liver cancer. But to remember in MASLD, in fact, you don't need cirrhosis. You might merely have MASH plus fibrosis, and that still puts you at risk of HCC. What are the factors influencing disease progression? Age, smoking, alcohol, type 2 diabetes, and genetics might be pro or actually protective. But unfortunately, we don't know much about this in Africa. So looking at the global etiology, epidemiology, MASLD is now the leading global cause of chronic liver disease, affecting approximately 38% of the world's population, or 1.7 billion individuals, the global MASH prevalence of 5.27, and the prevalence of MASH amongst MASLD patients at 16%. And the main drivers of MASLD were obesity and type 2 diabetes. This is a global heat map looking at the prevalence published recently in the GBD study of 2021, and you can see Southern Africa and North Africa and the Middle East where there's a high prevalence. So what are the at-risk populations? Males slightly more than females, 55% if your BMI is greater than 30, 66% in individuals with type 2 diabetes, 74% of metabolic syndrome, and 90% of those with more than class 2 diabetes, and you have multiple cardiometabolic risk factors. This just shows it in more detail in terms of the age standardized point prevalence rates and incidence rates. Globally, it's 15,000 cases per 100,000 people with an annual incidence rate of 608 per 100,000, with Kuwait, Egypt, and Qatar having the highest prevalence. And so we look at Africa, leading the way is North Africa and the Middle East with an age standardized prevalence of 27,000 and an age incident point prevalence of 1,000. And then in decreasing prevalence and incidence rates, with lowest being in central sub-Saharan Africa, which the prevalence rate is 11,000, and the age standardized incidence rate of 397 per 100,000 population. So you can see mainly in North Africa and then Southern Africa. So what about the global prevalence of MASLD amongst type 2 diabetics? It's 55% globally, and in Africa about 30%. Important, MASLD often precedes the development of cardiometabolic risk factors, particularly type 2 diabetes. And the prevalence of MASLD in patients with type 2 diabetes is more than twofold higher than the general population. The global prevalence of MASH amongst individuals with type 2 diabetes is 37%, and those with MASLD and type 2 diabetes who have underwent liver biopsy, up to 70% have advanced fibrosis. So what about this association of food security in terms of MASLD prevalence and liver-related mortality? This is the GBD study, which showed that the liver-related mortality across 204 countries was 2.92 per 100,000, and in sub-Saharan Africa, 2.34, and in North Africa and Middle East, 1.56, with the liver-related mortality associated with MASLD being older age, obesity, and metabolic risk factors. And then importantly, the role of food security, insecurity, which varies between high SDI countries and low SDI countries. In high SDI countries, we see a higher MASLD prevalence as the food insecurity increases, and this relates to an increased consumption of low-quality, ultra-processed foods. In contrast, in low SDI countries, food insecurity, which leads to outright malnutrition, as the food insecurity increases, we see a decreasing MASLD. But I think we need to remember that even in low SDI countries, there's increasing urbanization with increased access to these low-quality, ultra-processed foods, which are becoming an increasing problem. What about global alcohol consumption? If we look in Africa, we see once again Southern Africa, West Central with the main consumers of alcohol. And if we look at the total recorded and reported alcohol per capita consumption in Africa, it's 4.5 liters per capita. And the top 5 countries with the highest alcohol consumption are Tanzania, Eswatini, Burkina Faso, and South Africa. So what is the impact of alcohol on MASLD? We know the metabolic risk factors such as being overweight, diabetes, dyslipidemia, and alcohol consumption can cause liver disease. An important population-based study using transelastographic data from participants in Spain, which was the derivation cohort, and validating it against the US cohort. In the derivation cohort, there was just over 2,000 individuals with MASLD, 9% reported low and 14% moderate alcohol intake, and 76 cases had MET-LD. The CAP score of 275 was used to define SLD, with at least one cardiometabolic risk factor required to define MASLD. And if we look at the alcohol consumption in MASLD, low consumption was 5 to 9 drinks per week, moderate 10 to 13 for females, and 10 to 20 for males, and increased alcohol intake or MET-LD between 14 to 35 drinks per week for females, and 21 to 42 drinks per week for males, with significant fibrosis being defined as a liver stiffness of greater than 8 and at-risk MASH as the FAST score greater than 0.35. And so this is very interesting. The overall prevalence of SLD was 34%, significant fibrosis 7.6%, and at-risk MASH 14.8. But if we looked at the multivariable analysis, we showed that alcohol consumption was independently associated with significant fibrosis and at-risk MASH. So there was a dose-dependent increase in the prevalence of significant fibrosis and at-risk MASH observed between the number of drinks per week and the number of cardiometabolic risk factors. The validation cohort was 1,700 participants in MASH-LD, 17% had significant fibrosis, and 13% adverse MASH, and they validated the association between moderate alcohol intake and MASLD and the risk of progression. Other problem is the underestimation of alcohol. This is a consumption study taken in Canada with 16,000 residents, and they showed that the alcohol consumption compared to sales data was underestimated by 66% for spirits, 38% for wine, and 49% for beer. Regression analysis found that alcohol consumption was underestimated significantly more by younger drinkers and by low-risk drinkers, so 83% for underage compared to 70% for those over the age of 65, and low-risk drinkers 76% compared to high-risk drinkers of 49%. But underreporting did not differ by gender. So WHO, recognizing the concern about rising NCT, have a number of best buys. And for alcohol, measures to reduce alcohol consumption include increasing excise taxes on alcoholic beverages, ban or limiting alcohol advertising, and restricting retail availability of alcohol, and importantly, promoting a healthy diet and physical activity. So in summary, if we look at alcohol and food security and the role in MASLD, food security plays a critical role in MASLD disparities between high and low SDI countries. Low to moderate alcohol consumption is associated with increased fibrosis in individuals with MASLD, with alcohol increasing the risk of significant fibrosis and a dose-dependent superadditive interaction with cardiometabolic risk factors. In those without SLD, moderate alcohol intake can also increase the risk of fibrosis when combined with cardiometabolic risk factors. So there are no safe limits of daily alcohol intake in patients with an unhealthy metabolic status and MASLD. Thank you. So our next speaker is going to be Dr. Oyeleke. She's a consultant physician and gastroenterologist and hepatologist from Lagos University Teaching Hospital in Lagos, Nigeria. And she's going to present to us on nutrition and MASLD. Ganyot, over to you.
Good day, everyone. My name is Ganyot Oyeleke. I'm a gastroenterologist and liver specialist, and I work at the Lagos University Teaching Hospital, Lagos, Nigeria. Thanks for having me, and today we'll be discussing nutrition and metabolic dysfunction-associated steatotic liver disease, MASLD. I have no disclosure. And I'll be doing that under this outline: the introduction, definition, and nomenclature, steatotic liver disease classification, nutrition as a cause, the pathophysiology of nutrition-related MASLD, features, management, and the take-home points. Metabolic dysfunction-associated steatotic liver disease, MASLD, is a condition marked by excess fat in the liver. It used to be known as non-alcoholic fatty liver disease, NAFLD. And the term steatotic liver disease was chosen as a term for individuals with hepatic steatosis, meaning fatty liver, more than 5% of fat in liver due to various etiologies, causes. And these causes could include obesity, diabetes, dyslipidemia, high blood pressure, and several or many genetic factors. And these genetic factors are mainly family history of these conditions, like I mentioned, obesity, diabetes, and dyslipidemia. It is an increasing global disease, and a study has shown that within a 29-year period from 1990 to 2019, there's been about 121% increase in the number of cases and 45% increase in the prevalence of metabolic dysfunction-associated steatotic liver disease. And we're going to know why that happened later on. The world prevalence showed that about 42% prevalence in Southeast Asia, about 3 to 4% prevalence in Middle East and North Africa, and back home here, about 13.5% in Sub-Saharan Africa. A study done in Nigeria showed about 13% prevalence in Nigeria. And we know, like I mentioned, steatotic liver disease is the broad term, and it's subdivided into the metabolic dysfunction associated steatotic liver disease, which is where the one we're discussing today, MASLD. Alcohol associated or alcohol related liver disease, steatotic liver disease of specific etiology. So it could be drug induced, it could be from other monogenic causes, or the ones that we can't really find a cause for it, which it's called the cryptogenic steatotic liver disease. So when we take on nutrition, the nutrition on its own can be a cause of the steatotic liver disease. And what nutrition are we talking about? Excessive calorie intake leads to accumulation of fat. And this eventually will cause fat accumulation in the liver. Refined carbs and sugar, when high fructose in diets, will increase liver fat. This will also increase body fat, leading to obesity, where there is also an increase in liver fat. Unhealthy fats, these are saturated fats. They promote liver inflammation and worsen the progression of steatotic liver disease. And of course, the UPFs, ultra-processed foods. So we have to be very careful with these. They contain trans fats and additives, which have been found to worsen insulin resistance and cause weight gain, and can in turn result into steatotic liver disease. So this is the pathophysiology. How did it come by? So the green ones are the ones that are protective, while the red arrows are the bad ones. So simple sugars, you can see how does it result into fat accumulation. Simple sugars like fructose results into de novo lipogenesis, causing lipotoxicity, increased oxidative stress, mitochondrial dysfunction, and all these result into fat accumulation and, of course, progression of steatotic liver disease. Also, when we consume a lot of saturated fats, this contains high content of sodium and presence of several preservatives and additives and trans fats. This leads to insulin resistance and hyperinsulinemia, causes deregulated lipolysis, and these also result into fat accumulation. So these are the pathways to formation of fat in the liver. There's also the gut microbiome dysbiosis. So these result into fat accumulation. And I put this picture because this slide, because I feel it's important to note that we've had nutrition transition. Like I live in Nigeria, and we see a lot of transition from the regular local meal to the supposedly westernized or fast food available. So these we know that may impact the size, the weight. So we're moving from the lean body to the obese or overweight level. And this is, the Nigerians on the forum will be familiar with this meal. It's a meal of pounded yam. You can see equal portion, a small portion of pounded yam with mixed vegetables, with protein. And this is now being replaced with the fast food loaded with trans fats, with salt, with preservatives, and of course, it's balanced with soda. And also changing our meals and our diet, our nutrition is impacting negatively on our health. And it's important for us to be cautious and to revert all this. So for whoever is patronizing the fast food, we have to be very careful not to overdo. That doesn't mean you cannot have it once in a while. So in terms of the diagnosis, how do we know that someone has steatotic fatty liver? We usually know by doing an imaging. So imaging will be an ultrasound. In some cases, they may need to do a liver biopsy. So this is like an algorithm. So if the steatotic liver disease has been shown to be present from imaging like an ultrasound, we want to check if the patient meets the cardiometabolic criteria. Cardiometabolic will be, is there history of diabetes, or the patient has dyslipidemia, or is there obesity? If yes, are there any other causes of steatosis? If the answer is no, then you say there is metabolic dysfunction associated steatotic liver disease. If there are other causes, let's say the person also consumes alcohol, for example, then it becomes alcohol-related or metabolic dysfunction with alcohol liver disease. If there is no cardiometabolic condition and there are no other causes of steatosis, then we say there is cryptogenic steatotic liver disease. If there are other causes of steatosis and there are other specific causes like alcohol disease, like I mentioned, it could be drug-induced liver disease. So these are different ways in which we can, like a criteria to categorize the etiology, what is causing the steatotic liver disease. And the criteria can further be broken down into whether it's the adult or the pediatric form. So this is also the spectrum. Spectrum moves from a healthy liver. A healthy liver would result into simple steatosis if there's more than 5% of fat. And this can progress in about 12 to 40% of cases to MASH, which is metabolic dysfunction associated steatohepatitis. And in 15 to 20% of cases, this can result into cirrhosis, and in some percentage result into hepatocellular cancer. The last two stages are the scary stage. That is where we do not want to be. And you can see that even from the stage of MASH, metabolic dysfunction associated steatotic hepatitis, there can be reversal to simple steatosis and even to normal liver. So it's important to note what we need to do to prevent this. Of course, we know there are aggressors that can help that can aid the progression. And these have been highlighted: genetic factors, environmental factors like diet, gut microbiota, and complications, as we've said earlier, cardiovascular diseases, obesity, and diabetes. Clinical features, really, there are times when there may be no apparent clinical features, but in some cases there may be anxiety. Patients may complain of sleep issues, fatigue, sleep apnea, tiredness. Sleep apnea, particularly for those that are on the obese side. The clients may complain of right upper quadrant pain, and they may have generalized malaise and pain. At the late stages, when there's progression to advanced liver disease, there may be itch, there may be jaundice, ascites when there's fluid accumulation in the stomach, advanced liver complication like hepatic encephalopathy or variceal bleeding when there is vomiting of blood from the mouth. These are signs of advanced liver disease like liver cirrhosis. We know there is also deterioration in the health-related quality of life, HRQL, as MASLD or MASH progresses. So there's disturbances at work affecting daily activities. There's a fear of the challenge of stigma. And these are all the things that we have to put together when we're managing patients with metabolic dysfunction associated steatotic liver disease. And the management, the main stay in the management is lifestyle modification. So diet, exercise, weight reduction, and of course we have to target the components of the metabolic syndrome. So treat diabetes, treat dyslipidemia, manage obesity. Then in some cases we use liver-directed pharmacotherapy. And of course, for those that have already developed complications, we want to manage the complications of cirrhosis. Nutrition could be a cause, like I said earlier and we've discussed, but could also be protective. So what nutrition helps to protect? And I think this is an important aspect of this discussion. Mediterranean diet, so whole food, healthy diet, and use of antioxidants. High fiber diets, so foods, lots of fruits, lots of veggies and whole grains. They help to protect and to help to manage and treat metabolic dysfunction associated steatotic liver disease. Omega-3 fatty acid reduces liver fat and inflammation. Coffee has been found to help to lower the risk of fibrosis. And it's been advised that clients with MASLD would advise to reduce low carbohydrate, low fat in diets, and increase polyunsaturated fatty acids and reduce saturated fatty acid. And of course, we need to avoid alcohol intake, even though we know that this is not from alcohol, but little bit of alcohol can also worsen the disease. So it's advisable to avoid alcohol as much as possible. Other macronutrients that have been found to be helpful will be vitamin E, and vitamin E helps to reduce oxidative stress. Vitamin D deficiency has been linked from studies to progression of liver disease. So supplementing with vitamin D is also very important. Choline, which is essential for fat metabolism, is important. Choline is found in peanuts, in walnuts and all that. So it's important. Polyphenols found in green teas and berries help to also reduce inflammation, and they've been found to be quite helpful in metabolic dysfunction associated steatotic liver disease. So this is just a picture of some of the foods that have been found to be beneficial. Olive oil, garlic, oatmeal, the greens, so broccoli, lettuce, kale, so it's important, cabbage, cucumber, walnuts, avocado, and all that. Weight loss is very important, and studies have shown that 5 to 10% weight loss improves steatosis and fatty liver, and caloric restriction to between 500 to 1,000 kilocalories per day would also help to reduce liver fat. Intermittent fasting helps to enhance insulin sensitivity, and we have to, of course, manage the underlying cause, treat type 2 diabetes, treat dyslipidemia, and manage obesity. In some cases, managing obesity may require even bariatric surgery. Now, in conclusion, metabolic dysfunction associated steatotic liver disease is strongly linked to our diet and lifestyle, and renaming it from NAFLD to MASLD aims to better reflect the underlying metabolic causes of the condition and reduce the stigma associated with the previous terminology. Reducing harmful foods, which I have highlighted, and adopting a healthy diet is key. Weight management and proper nutrition can prevent and reverse metabolic dysfunction associated steatotic liver disease. Thank you very much.
Thank you, Dr. Oyireki, for that excellent overview. Just to remind everyone, please put your questions and comments in the chat so we can address it during the panel discussion. So our next presenter is going to be Professor Manal Al-Sayed. She's Professor of Pediatrics at the Ain Sham University in Cairo and President of SOLDA. Manal, over to you.
Thank you very much, Wendy. And I'm going to start by some key facts here, that both malnutrition is not only about obesity, but severe malnutrition may also cause hepatic steatosis and mitochondrial changes. So both severe malnutrition and obesity, overfeeding, may lead to hepatic steatosis. And malnutrition also is common in chronic liver disease. Chronic liver disease in children in Africa is very common. and malnutrition may worsen prognosis. Also, many liver disorders are associated with nutritional deficiencies such as vitamins and minerals. MASLD, however, is related to an unhealthy diet and has become the leading cause of chronic liver disease. It's worthy to note that it is expected that the prevalence of obesity among children in Africa will see a major increase from 5% to 14% by 2035, according to the World Obesity Atlas. And the annual increase in childhood obesity in Africa is highest in Angola, followed by Rwanda, Tanzania, and Uganda, where the rate is around 8.4%. So there is a global paradox of malnutrition. One part of the world population, no access to food in quantity, quality, necessary for healthy life, and another large group of people chooses to excessively high-calorie diets, low in nutrients and fiber. So obesity has doubled since 1980. In 2014, there was more than 1.9 billion adults overweight, of which 600 million are obese. Most live in countries where overweight causes mortality than malnutrition. And the number of children suffering from metabolic disorders, around 155 million, exceed the number of children suffering from malnutrition, 148 million. Some countries, for example, have practices like what they call the lib law. They bring in the young girls because this is the image of beauty for the females to be obese and to get married to wealthy men. So they force feed them since a very young age. These are some of the rural villages in Mauritania. This has stopped long ago, but after some of the political changes, it came back again as one of the very serious practices in one of the countries in Africa. So according to the Global Nutrition Report, Africa has a modest progress towards achieving global nutrition targets. If we look at childhood stunting, which is related directly to nutrition, 6 are on course, 38 countries have some progress, but 10 no progress or worsening. And if we look at the child overweight, only 28 are on course, 25 off course, and 1 has no data. Also, if we look at the child wasting, 19 countries on course, 12 some progress, 10 no progress or worsening, and 13 no data. And there is hardly any data in all 53 on sodium intake, on raised blood pressure, on obesity, except maybe we had recently published a paper on the prevalence of obesity in 50 million from Egypt, 50 million of the population screened during the testing of hepatitis C. So if you look at the child and adolescent nutritional status, you'll find that overweight is increasing over time for both boys and girls, more for girls than for boys. And the same we've seen in women. 50% of women seen were either overweight or obese in the Egyptian population, while 25% of men were either obese or overweight. But the thinness is also increasing over time, and more so with the conflicts that are ongoing. And same here, we find that obesity for both boys and girls has increased over time, more in girls than in boys. And if we look here at this photo, you'll find that in some areas, like in Sudan, for example, the UN is struggling to get food to starving millions. So undernutrition is also happening, but undernutrition may also lead to liver damage and may lead to steatotic liver disease. So 1 in 3 children in Africa has in severe child food poverty due to inequity, conflict, and climate crisis. That's according to UNICEF. Nearly 64 million children in Africa less than the age of 5 years, or 1 in 3 are experiencing severe child food poverty. Millions of children less than 5 are unable to access and consume a nutritional and diverse diet. And Africa is home to 1/3 of 181 million children living in severe child food poverty across the world. And we have those countries are carrying the heaviest burden of those living in severe child food poverty. But there are very strong initiatives, and I'm going to let you know about them in my slides. As we can see here, that 2 out of 8 defined food groups per day. If those are consumed by children, this is considered as severe child food poverty. 4 out of 5 are fed only breast milk and milk or a starchy staple like rice, maize, and wheat. Less than 10% of children are fed fruits and vegetables. Less than 5% are fed nutrient-dense foods such as eggs, fish, poultry, or meat. And conflict, as well as climate crisis, had a severe effect, tremendous impact on families' abilities to feed their children, causing severe disruption in food production. So nutritious food becomes available, less available, more expensive for vulnerable households, and parents are unable to feed their children. So basically, they are feeding their children unhealthy food. So those are the categories of food child poverty. As you can see, from 0 to 2 food groups per day, they are living in severe child food poverty. 3 to 4 food groups per day, they are living in moderate child poverty. 5 or more, they are not living in child food poverty. So this is one of the studies that has been published a couple of years ago, looking at undernutrition in sub-Saharan Africa, and evidence from DHS surveys from 31 countries. Undernutrition was linked almost half of all deaths in the 5-year-old children. The study involved 189,000 children less than the age of 5. Nearly 26% of children in 31 countries were stunted, 6% were wasted, 21% were underweight. And 31% of children whose mothers had no education were stunted, 9% were wasted, and 28% were underweight. And of course, the significant and adverse nutritional status was associated with maternal age, education, household wealth, residence, among others. And child undernutrition remains a major health challenge in the low and low middle income countries, and children of women aged 15 to 24 years were more likely to experience adverse nutritional outcomes compared with children whose mothers were 25 years and older. Education plays a very important role in the child nutritional status, and improvement in sub-region would require intense efforts at government levels and community levels as well. So those are the risk factors for food poverty: ineffective food systems, failing to provide children with nutritious, safe, and accessible options, families' inabilities to afford nutritious food, and parents' inability to adopt and sustain positive child feeding practices. So they resort to cheap, unhealthy, ultra-processed foods and sugar-sweetened beverages, which are aggressively marketed to parents and families as well as to children. Unhealthy food and beverages are consumed by an alarming proportion of young children experiencing food poverty. And those are some of the initiatives. World Vision, for example, they have some fast facts about hunger crisis. More than 1 billion in Africa struggle to afford healthy food. Around 30% suffer from stunted growth. 57 million more people facing hunger after COVID. 868 million experienced moderate to severe food insecurity in 2022, and hunger worsened. And the vision of World Vision supported more than 25.4 million people, including 40 million children, including 18 countries, to support their feeding. And there are some initiatives that are really great, including the school feeding programs, and those are being integrated now into national strategies in Africa. And this is really important. School meal coverage increased by 30%. From 66 million in 2022 to 87 million in 2024. And this is driven by funding from African governments. Of course, the hardest hit areas, like the areas where there are conflicts, they are still left behind because there is also disruption of education along the meal programs. Of the 21 million in crisis-hit countries, it's projected to receive the World Food Programme supported school meals this year. Many live in Africa. And these are some also of the African Development Bank initiatives. They are stepping up also to save thousands of children at risk of dying before their 5th birthdays with the school meal programs. with an investment of $990,000. The project reinforcing, for example, the efforts by the Burkina Faso government to give children balanced meals. And they launched this initiative as an advocacy tool that would enable African countries to work with partners to boost nutrition. And through the banking and nutrition program, a partnership with big philanthropy and foundations, the bank is leading a fight against infant malnutrition and providing healthy nutrition for children. In Egypt, we have a very nice program also by the Egyptian Food Bank. It's for the whole population, but there are special programs for children, especially for schools. It's called Build Tomorrow program. They give daily hot meals for children in nurseries and schools containing essential nutrients to combat malnutrition and support the health of students, but also educating the parents and students about healthy nutrition and including the families and the parents in the kitchen in cooking, just to give them an idea of how to cook healthy meals for the children to improve the quality of food given to children. They have many initiatives for children and their families and the mothers as well, including the First Chance program, fighting stunting, feeding an orphan program. Kafara, that's people give out money when they and it's actually, the program is called Food as Medicine, same as the title of our webinar. And they have this donations, they accept donations from everywhere. And they've been very active for many years now, and they're doing a great job. So those are what we need to do. It's to include the target related to global nutrition within national policies to reduce anemia and reduce low birth weight and increase prevalence of exclusive breastfeeding, reduce childhood stunting, wasting, overweight, reduce adolescent overweight, reduce salt, sugar, and improve the blood pressure. And we need legislations, of course, for salt iodization, for sugar-sweetened beverages taxation, policy to reduce salt, sodium consumptions, and policy to limit saturated fat acid intake, as well as food-based dietary guidelines. And those are some of the food groups that need, and healthy groups that need to be consumed on a daily basis, including the legumes and grains, and of course, vegetables. And those are my key messages. Efforts at improving nutritional status of children should include poverty alleviation initiatives at individual and household levels. I think we need to work with families, educate mothers, educate families. Children buy unhealthy food with their parents' money. They do not earn their own money. So they have to be educated since a very young age, even at the time of weaning, how to eat better and increase women's educational level and improvement in living conditions in rural areas. Thank you very much.
Thanks, Manal, really for highlighting the importance of nutrition in children if we're really going to combat the real global problem of MASLD in adulthood. Thank you very much.
The next speaker will be presenting the patient and community perspective. We'd like to hear from Danjuma Ada. He's from World Hepatitis Alliance, and he's based in Nigeria. And the title of his lecture will be My Liver, My Life.
Hello, and welcome to this beautiful webinar on World Liver Day. My name is Danjuma Ada. I'm the past president of the World Hepatitis Alliance. I'm also a member of the Society on Liver Disease in Africa, and I chair the Africa Viral Hepatitis Action Group. It is my pleasure to discuss my liver, my life. And why is this very critically important to me? Because I'm also diagnosed with hepatitis B. So I'm talking about my own liver. And I know, why should you care as a person? And how does this connect to you? It connects to you because you have a liver. It connects to you because your liver is the largest organ in your body that literally keeps you alive. So I'm sharing the patient's perspective on liver health and why it is important for you to protect and take care of your liver. So my personal journey into hepatitis care is that I was diagnosed with hepatitis in 2004. And as you know, hepatitis B is a viral infection that affects the liver. So the diagnosis was shocking to me because I thought about, all I knew about then was that hepatitis would cause me liver cancer and my liver will be inflamed. So I didn't know how it was going to be in terms of how I would take care of my liver and how at the end of it life would be. There was this fear, there was a misinformation, there was a stigma I felt because people would think, because I mean, they thought about hepatitis infection usually is just sexually transmissible, whereas I got mine in the workspace, people would just judge me, right? But what I did was that I transformed my diagnosis into advocacy. And that's why this discussion is important for everyone. I had the shock of diagnosis that I had hepatitis in my liver, but I overcame that shock. Rather than pulling me down, it helped me and turned it into advocacy. That's when I even started my local charity organization. Now, why should you understand liver health? Understanding liver health is very important, even as a community person. To the layman, what is the liver? The liver is just like the engine block of an automobile, right? The liver's critical functions includes detoxification, metabolism, immune function. But the common diseases that affect the liver are hepatitis A, B, C, D, E. There's also the fatty liver, there's also the cirrhosis, and the big one we all are running away from, which is liver cancer. Now, why the silent nature of these diseases makes it very crucial and important for us to understand why we need to be tested, because it's mostly silent, including even the cirrhosis or fatty liver disease. Now, hepatitis B, I said earlier, I was diagnosed in 2004. And it was shocking to me. I worked in the health sector, but I didn't understand what hepatitis B was. It was much later, through studies, I understood that it's a viral infection that affects my liver. Now, in Africa in particular, hepatitis B affects millions of people within this region. As a matter of fact, Africa carries over 60% of the burden of hepatitis B. And hepatitis B is transmitted majorly through the major body fluids, which excludes sweat. That is where there's a lot of misconception again, mostly through mother to child, through during delivery, and then sharp contaminated objects. Very little science talks about saliva, but not much. And then, of course, as I mentioned, mother to child, blood transfusion, on-screen blood transfusion, contaminated objects, and then, of course, on-screen blood. So the role of mother to child transmission is very critical to us, especially in this region. There are a lot of myths and a lot of misconceptions about hepatitis B. Now, how does stigma affect care and mental health? A lot of people feel they don't even want to be tested because of the lack of information about hepatitis. So it limits people's access to go and get tested. It affects mental health. For me, I really was mentally affected. When I say mental, meaning fears, anxiety. I didn't know how to discuss the status of my hepatitis to my spouse then, my fiancé then. So my mental health was so affected. And over time, I keep checking if I will stand before the mirror, I want to touch, because the liver is body side of the body. I keep touching my liver side. I want to see, is my liver enlarged? Am I developing cirrhosis already? Because hepatitis B affects the liver. So it really affected me mentally. I was afraid of my future, afraid of my career, afraid of my relationships. There was a time when before my wife got vaccinated fully, I had to stop sexual relations because I was afraid of transmitting the virus to her. So these are challenges that affects people mentally, right? The fear of developing liver cancer because your liver is enlarged, because your liver is affected. So my liver, my life. Hepatitis B shaped my life. It's not just a diagnosis, it's a human condition. So my experience about it was that I had to first internalize it. How does it affect me? But when I gained knowledge, which is part of what we're doing here, I now understood that it's not just casually transmissible, and I could live more longer life if I started treatment. That's why the role of education is very important. So many people are afraid of hepatitis because of the stigma. They think sweat can transmit it. So you see in homes, they even send people away that have hepatitis, and that is not true. It cannot be transmitted through casual contact. Now, how do you protect your liver? How do you protect hepatitis B in particular? There's a safe vaccine that protects you if you're vaccinated through the proper way. For babies, it is administered at birth, immediately after delivery. For babies, they're given that. For high-risk populations like healthcare professionals, or other people that live high-risk life, it's important you get tested. And the testing tells you if you're negative, you need to protect your liver, you need to be vaccinated. Then lifestyle choices that support liver health. Dieting, good exercise, alcohol in moderation, or avoid it completely. Avoid it completely if you want to avoid problems, right? And then good dieting, good exercise, and regular screening, right? Recommendations are very important. And there are simple diagnostic tests for liver health monitoring. It's important for us to understand those. And then, if you're already infected, how do you care for your liver? You need to adhere to treatment. You need to adhere to regular monitoring. You need also to build the resilience. What does it mean? You need to fight it. You need to build a support system. You need to notify close family, close relations, and tell them about your status. So you need support from people that will help you in dieting. Maybe as a young person, you don't have access to financing. You need people that will help you with resources on dieting. You need community groups. You need to build this community, this system, either support groups or through the family support. Now, for my journey from being a patient to a global advocate was around the resilience, was about education. I listened to podcasts, I listened to scientific webinars, I went to knowledgeable sources. For example, this meeting organized by SOLDA is one of the avenues by which you need to be educated and understanding what hepatitis is and how you need to care for your liver. Education empowered me, and it made me understand that it wasn't a death sentence if you're diagnosed early. It made me understand that early treatment would protect my liver. It made me understand some of the misconceptions. So education is very, very important to help you to thrive and then to build the resilience on liver disease and how to care. Now, what are my calls for you as a person that is listening, or the people that are listening? Why should you care for your liver? Your liver is the largest organ in your body. But if you have a liver disease already, you need to be more careful with your lifestyle. You need to be more careful with your dieting and living, and then you need to be careful to avoid infection, all right, or super infection or co-infection with other diseases. If you have hepatitis B, you need to check your diabetes status, you need to check your HIV status, you need to check other health conditions that might make your liver condition worse. So you need to get tested regularly to monitor your health, monitor your life. And then if you're negative, if you're not infected, you need to get vaccinated. Then we need to increase awareness about hepatitis and liver disease. Awareness will help to reduce misunderstanding, misconceptions. Awareness will empower you to be able to live positively. Awareness will empower you to understand even people living in your household that might be living with hepatitis, they cannot just transmit the virus to you casually. And it also, we need to share knowledge. And then we need to advocate for better policies in countries for babies to be vaccinated, policies to make sure people should be tested, and those that are diagnosed should be treated. Policy in health financing, policy to make sure that nobody is left behind. And we need to empower patients to live beyond their diagnosis. And that was what helped me. My diagnosis did not shape my life by weighing me down. My diagnosis shaped my life by making me an advocate. Rather than pulling me down, rather than making me despondent, rather than making me to succumb to self-pity. A lot of times some of us, we get diagnosed, we indulge in self-pity. We just want people to empathize with us. We just want people to help us. No, self-pity might not be helpful in making you to build resilience. So you need to be empowered with knowledge. Go to verifiable knowledge sources like WHO, like SOLDA, or World Hepatitis Alliance, and get accurate and correct information that will help you in building resilience. Now, what did I talk about? Your liver, your health is your responsibility. It is your responsibility to protect your liver. No one else has the power to do that except you. And I encourage you that please live a more positive life. If you're diagnosed with hepatitis or other liver disease, adopt healthy lifestyles, listen to your doctor or clinicians, adhere to your treatment regimens, and protect your liver. Because your liver is your health, and it's your responsibility to protect your liver. Thank you so much, and I wish us a wonderful Liver Day. Thank you.
Manal, I think you're on mute.
Yeah, thank you very much, Danjuma, for showing case how a patient himself can be an advocate and support other patients in removing stigma and in looking at themselves in a different way and leading a healthy lifestyle. I think we can start the panel discussion now. So over to you, Wendy, with the questions. I think there are 2 questions I can answer, but I think the first question was for yourself.
Thanks, Manal. So please feel free to add any questions to the chat. We're here to try and help and answer questions and ready to engage in discussion. So one of the first questions to me was, surprised to see a country like Burkina Faso in the top 5 alcohol consumers in Africa. Does this ranking take into account local beer consumption, and how was the equivalence made? So the data on alcohol consumption looks at pure alcohol per litre per capita, and the data comes from the WHO report, the World Bank, and the Global Burden of Disease studies. And so what they look at is a combination of recorded and unrecorded alcohol intake. I mean, what's quite interesting in Burkina Faso is that obviously up to about 60% of the population are abstinent, but amongst those who are not abstinent, there is a increasing tendency, and you can see this over the past sort of 10 years, there's increasing alcohol consumption. So increasing heavy alcohol consumption and binge drinking has been reported. So that's how we get into this thing. I mean, I think the estimation now is about 11 litres per capita in those who actually are drinking within Burkina Faso. And I think this is an important thing that we tend to underestimate, because it's a really important negative cofactor in countries where hepatitis B or hepatitis C prevalence may be high. So this is, yeah, all these data look at a combination of recorded and unrecorded alcohol. I think there's another question for me, and then I'll address the others to Manal and Ganyat. Does alcohol cause hepatitis B or C? So hepatitis B and C are viral causes of infection, and as we know, within Africa, hepatitis B is endemic. We account for about 63% of the new infections within sub-Saharan Africa. And then hepatitis C, we have areas of high prevalence in Central Africa, North Africa. But the very important thing is that alcohol, if you add alcohol to that mixture, it promotes the progression to fibrosis, cirrhosis, and increases your risk of HCC. And I think the other thing you saw in my presentation is that depending on the number of cardiometabolic risk factors and the amount of alcohol, you might have really what's considered safe alcohol. But if you have 3 cardiometabolic risk factors, this increases your risk of developing significant fibrosis and cirrhosis due to MASLD. So I think we underestimate the contribution of alcohol as a negative cofactor in any patients with chronic liver disease. I think the next question, Manal, is for you.
Yeah, I think there is one on education
Yes.
in Zimbabwe, that people are educated.
Yeah, maybe I'll take the one for Ganyat and then follow with you, Manal. Ganyat, the thing was, did you study, for instance, whether traditional Nigerian meals have protective effects on liver disease? Do you plan at a broader African or at least West African perspective to validate some meal in the wake of the famous Mediterranean meal? So I mean, we all talk about Mediterranean meal, but how do we actually apply this to within our own countries and regions? Ganyat, over to you.
Thank you very much for the question. I do not have details of what specific or any study actually studying the effect of Nigerian meals, for example, on the liver. But what I know is the content of our food that is most of them rich in fiber, lots of fruits and vegetables, the traditional meals, of course. But we also know that there's also a lot of oil content and all that. So I do not have any details. I don't know if others are from other African countries, but I feel if we try to incorporate increase the fiber content, add lots of fruits and veggies, lots of green leaves, and I think that would be good. But it would be nice, like the person suggested, to have real data on what type of meal in Africa is best, like we have in the Mediterranean. So I don't know if others have inputs on this.
Yeah, I think there is one on education in Zimbabwe, that people are educated.
Thank you very much.
Yeah, I think there is one on education in Zimbabwe, that people are educated.
Thanks, Ed. I think one of the other problems that we're seeing within Africa is the increasing urbanization, and so a change from traditional diets to the sort of high, polysaturated fats, high proteins, high sugar content foods, and often the quite significant marketing and sort of status associated with these kind of diets, which is something that we probably have not been very good about addressing ourselves as hepatologists and gastroenterologists. Manal, there's a question in terms of education playing an important role in nutrition. This is somebody from Zimbabwe. Most people are educated, but there are no jobs, hence children will suffer. So really, how do we actually address education? I think just to expand on that, particularly in the setting where the economic status is difficult.
I think it's multi-level. We have to start with families. So we have to approach families first, and the community here plays a very big role, because usually in villages, for example, and in rural areas, there are village leaders, and there are women leaders, and there are community workers who can help in educating people on how to cook healthy food to their children, even with the most affordable type of food that's available. And most of the African countries have available grains and fruits and vegetables, and that's very basic, and that's what we really need to feed our children properly. The other thing is the people have to put their heads together to create some kind of attractive looking food for children. So all the time, we think, as a pediatrician myself, I innovate recipes for mothers, and I give them recipes and things that they do for the children that looks really nice, so that it can be attractive for the children, and to get away from food that's very, very cheap and marketed, but with high sugar content, with high fat content, with high carbs, and very, very harmful to their livers and their health. Zimbabwe, for example, I looked it up. They have legumes, they have grains, they have sweet potatoes, pumpkins, which are very cheap and supposed to be very affordable. So I think it's a matter of people working together, physicians, community workers, students in universities and colleges. They can be engaged in this as volunteers, working with their parents, with their families, with their neighbors. And school children have to be educated about healthy food as well. And when we talk to children all the time, they listen. When I have a child who's either undernourished or obese, and I really talk to him sincerely about what's good for him and what's bad for him, they come the next week and the week after telling us, yes, are you happy? Can you give me a star, for example, or a sticker or something? Because I've been very good. I've done this and I've done that. So when we give them incentives, I give them stars, and I give them stickers, and I give them nice toys. So when they are good and they eat healthy food, and they are really proud of themselves after some time. So I think we have to work hard on this. We forget, we just examine patients, leave them go, let them go, and we don't tell them anything. And we don't do the effort. I think we need to do the effort as physicians, community workers, the community, the civil society. Everybody needs to work together to improve the health of our children. And I think that goes also for the other question that I think there was another question to me, addressed directly to me about food. Yes.
About the food bank. Does the food bank differ from the school food program in many African countries? How effective is it? And could it be an example for other African countries?
Yeah, it is different. The food bank was created around 15 years ago. And with it's an NGO with the objective to end hunger in Egypt by the year 2030. And they've been doing very well, actually, for both adults and children. They prepare boxes and cartons. They rely completely on donations of the public. We donate, all of us, at all times, even during our feast, where we are, our Eid, our Bayram feast, we do, everybody has a sort of a slaughter. So you pay to the food bank, and they do it for you and distribute the meat to the poor people in the most rural places and the farthest villages. And they have special programs like the school meal program. They have special programs for orphans. They have special programs for stunting. They have special programs for pregnant women, for breastfeeding women. They are having, of course, the support of the government politically, but they rely completely on donations. The other programs that are being done in Africa for school meals, that's through the African Development Bank and through other organizations and the African Union. And that's also an excellent program, because that would ensure that children are going to get a good, healthy meal at least once a day to prevent hunger and also to prevent obesity. And it teaches the children how to eat healthy food. So I think the Egyptian Food Bank program, we are very proud of it. It's a totally run through donation money.
Thanks, Manal. Then I think there are two questions for Ganya. To what extent do high protein containing foods impact on our health, particularly in the context of hepatitis?
Should I go ahead?
Yes, go ahead, Ganya.
Okay, thanks. Okay, sorry, I'm on the road, so the network is not so good. Okay, yeah, thank you for that question, because where I practice is always what the patients with hepatitis speak. They come to tell me that, oh, they've been told not to take a high protein diet. They've been told to avoid anything containing protein. So protein is fine, even in the context of liver disease. And that is what we try to tell them. You still have to maintain a balanced diet. So it doesn't have to be too high in protein, but moderate protein consumption is okay. It is only when you have developed, maybe for those with hepatic encephalopathy and all that, do we at that time restrict protein. So you should still have your normal balanced diet, even in the presence of viral hepatitis. So it's important, and it's good that this question was asked, because I've been asked quite a number of times that, oh, someone said I shouldn't eat meat, I shouldn't eat eggs, I shouldn't take beans. So you can have your regular protein in your balanced meal. Doesn't be excessive, and there's no restriction to protein in viral hepatitis, only when there are complications like hepatic encephalopathy.
And then there's another question for you. It's already
is there any other?
Yes, there's one more here. It's already difficult to retain hepatitis patients in care. How can we improve nutrition issues for these individuals?
Sorry, come again. I
think it's in terms of difficulty in keeping patients with hepatitis in care.
It's in the chat.
Yes, and then how do we improve nutrition issues?
Okay, it's already written. How can we improve it? So the main thing is actually, I think the first step is education. And you have to let them know the importance of healthy eating or healthy lifestyle, improving your nutrition. So that's the first step. I know that there are also other challenges that we have in Africa in terms of resources and all that. But the main thing is just to educate them that, I mean, the fact that you have hepatitis B, you should still have a good nutrition, balanced diet, and, talk to them. There are other ways to, like what Danjuma has, like a patient advocacy group. So maybe that also would help. But I think the most important thing is education.
Thanks, Ganya. And I think we need to sort of start addressing it, as Manal said, we need to start with the family, when people are children at school, including this in sort of curriculums. And then I think we need to sort of break down these silos of healthcare. I mean, nutrition really crosses all aspects of healthcare, and particularly if you look at MASLD, the major causes of mortality is actually not liver disease, but cardiovascular disease. So I think one needs to actually improve it across particularly primary healthcare.
Yeah. I think it's also maybe important to involve the nutritionists, because sometimes in our clinics, we're so burdened with patient care that we don't have enough time to talk to them. And also, I mean...
Sorry, Ganya, we've lost you.
Yeah.
So I think, I mean, whilst we're waiting for Gunny to come back, basically sort of saying that we probably don't utilize our nutritionists and dietitians effectively, and really should have that part of a multidisciplinary team when we're managing patients with MASLD. Sorry, Gunny, you're breaking up quite badly. Maybe you try. So there's another question here in terms of alcohol and liver disease. Could indirect effects of alcohol, increased risk-taking behaviors, increased likelihood to eat UPFs be considered an ongoing risk factor for MASLD and viral hepatitis? So, I mean, I think in reality...
Sorry, I went off briefly.
Okay, come back in. And
yeah, sorry. So I was just talking about involving the nutritionists and the dietitians in the care of patients, that most times we do not have enough time to actually sit these patients down to discuss this. So if it's possible to have like, a team of the hepatologists, the nutritionists, the pediatricians, to actually talk to them, talk to the families, talk to the parents of the kids that have all this. So incorporating that, and most times they ask for the local food that is good, and sometimes we may not even have all the details, but the nutritionists will be able to assist with that, or the dietitians and all that. Thank you.
Thanks, Gunnar. So, I mean, I think just in terms of alcohol, I mean, that's going to really be a negative cofactor for all patients with chronic liver disease. And we really need to address alcohol when we engage with our patients. But I think importantly, in a non-judgmental way, to actually try and understand, are they drinking on a regular basis? Are they binge drinking? Are they drinking in response to stress? Because absolutely, I mean, depending on the pattern of drinking, that's going to potentially increase your risk-taking behavior, risk of acquiring other viral hepatitis or HIV. So it's really is a holistic approach to the patient and what is actually driving the underlying cofactors that will actually make liver disease worse. So it's part of a holistic approach to the patient, and we need to be able to address, I think, in terms of MASLD, obesity, alcohol, it's really looking at using a multidisciplinary approach and to actually utilize one's resources, that one actually has a non-judgmental approach to it if one's going to actually be successful. Then there's an important question raising the concerns of vaccination, particularly hepatitis B. Do you have viable information on the availability of the hepatitis B vaccines and financial considerations? So that's really important. So if we look within sort of WHO Africa, universal hepatitis B vaccination in majority of countries is often given at 6, 10, and 14 weeks, because initially it was felt that the main sort of transmission was horizontal under the age of 5 years. So in fact, if we look at the sort of general coverage of universal hepatitis B vaccination, we're sitting at about 78% in WHO Africa, and we have dropped down, remembering that one should be aiming for 90%. The big problem comes with the birth dose vaccine, where only 15 countries have introduced that, and so that's about 18%, and a large proportion of those are not actually administering it within those first 24 hours, which you really need to do if you're going to prevent transmission from mother to child. And so if we look at the WHO 2024 report, it showed that for the birth dose vaccine, that was mainly out of pocket. So remembering the universal vaccination is part of the EPI schedules of patients of the country, and so it's usually a hexavalent or pentavalent vaccine. But for the birth dose vaccine, that needs to be the monovalent vaccine, and if one's actually vaccinating contacts or high-risk groups, that also needs to be the monovalent vaccine. And so, in fact, the access to that monovalent vaccine can be difficult, and unfortunately, for the mother-to-child prevention, it's mainly out of pocket. So the important thing, though, is Gavi in June 2023 actually recommitted to supporting low-income countries in accessing the birth dose vaccine. But that does require that the country Ministry of Health actually put forward a proposal that they require, showing the reasons why they need economic support for that, and also showing evidence of a sustainable program. So I think it's up to us to actually motivate for our ministries of health, if we actually fall into that category, to get access to the Gavi supported program. Manal, you might want to comment further on that.
Yeah, I think that's a huge issue now, because Gavi, I think now with decreased funding coming from the US, are going to have problems in implementing the programs with the birth dose vaccination in the low-income countries. So I think it's about also the advocacy that we need to do as physicians, as community workers, as civil society, as NGOs, with our governments, to make sure that our governments are contributing to this program as well and making the vaccine available in our countries. This took us, I'll give an example in Egypt, for example, when we started our program with viral hepatitis in 2006, we pushed towards a program for vaccination of university students who were not previously vaccinated when they were young, because there was no implementation of the vaccination at that time. And not only that, we made huge awareness among the country. We got in-kind money to vaccinate students in medical schools, and we ended with a firm decrease in universities where students are at high risk for compulsory and obligatory vaccination. And we made sure that the government gave the vaccine at a very, very low price that's affordable by everybody. So I think there is a lot of work that we need to do in advocacy as well, if we want our patients to be better, if we want our community to be better. So we have to be proactive, all of us. It's not only about being a physician, examining patients, and the patient goes home, but we have to be proactive, talking to the key stakeholders and bringing in as much as key stakeholders on the table as possible to be able to implement those programs and get down the price of the vaccine to the minimum. I believe also that the work done by the African Union now and the Africa CDC, trying to have a sort of a pooled procurement for the whole continent, might help in bringing down the prices of the vaccines to the lowest. And we need to continue our conversations with them to make sure that the vaccine is available for everybody.
Thanks, Manal. There's just a comment. The existing school food program in Nigeria, there is an existing school food program in Nigeria. Sharing evidence to government and other stakeholders via the school health program may be a good opportunity to reduce steatotic liver disease amongst children. Yeah, I think absolutely. I think we need to really look at the resources that we have, what is actually working effectively, how we can actually expand it within our regions, and then share, importantly, to share knowledge. Then there's another comment. When it comes to non-viral related health challenges, what are the current urgent problems on the continent, and how can other stakeholders collaborate to improve their health status outcomes in the general population? Ganya, do you want to, and Manal, do you want to comment on that?
So I'll start with Ganya.
Yeah. I'm not sure. Ganya, can you hear us?
You're on mute. Can you unmute, please?
Sorry. Hello, can you hear me?
Yep.
Yes.
Okay, thank you. So when it comes to non-viral related health challenges, what's the current? So, I mean, this is the next most urgent, which is what we discussed today, the MASLD and, obesity and undernutrition. I mean, that's the main driver, and that's what we're discussing today. So, and it's the urgent need is now for the stakeholders to get involved, assisting with the right resources. So education is important, like we're highlighting, to let people know that these exist, to have data from different countries, to make available the appropriate food and things, the appropriate food types that would be beneficial, and things that could aggravate, and knowing what to avoid and what to have, and to get governments involved in, the school program, like you've highlighted, currently ongoing in some countries, but even in Nigeria, I'm not sure the coverage is everywhere. So to highlight the the importance of undernutrition. So government policy is very important. Government support is very vital. And also advocacy groups, so they can do a lot. They are driving hepatitis already, so they can also drive others as well. Highlighting that alcohol is very, very vital in the progression of liver disease, both for non-viral and for other viral causes as well. And alcohol is readily available I speak from Nigeria, and I know that it's available in different forms, both the local forms and the refined forms. I'm not sure there's any strict regulation in terms of accessing alcohol consumption, even for younger adolescents. So these are things I feel the government policies will also aid, in addition to the health care workers and getting the information to the population as well. So yes, I think we can do all that. And of course, collaboration, the stakeholders will be the policymakers, the healthcare workers, the advocacy groups, and schools, and all the other groups involved in the care. Thank you.
Thanks, Ganya. Manal, any comments?
Yeah, can I add? Thank you, Ganya. You've highlighted most of everything, but I think also with that we need to work with women of childbearing age, because they are the core of the families. And we can start with primary healthcare facilities. We can start in schools at a very early age. And also maternal and child health centers are very important to educate women on how to feed themselves and their children properly and how to feed the family properly. Of course, we need to engage the nutritionists, but above all, also we need to include the media. The media is a very important tool, whether it's social media or visible media or audible media. It's all really important, and talking to people about their health in general and liver health in particular, I think is really important. If we engage the media and we engage celebrities and we engage influencers on social media, that is also a very important tool, especially for the young generations that are using those tools now, and they listen to the influencers and they listen to the media people and the celebrities. So I think that's something that we can add also as key stakeholders, and we need spokespeople to speak about this more often. Thank you.
Thanks, Manal. And then I think we've got time for one last question from Ponciano. One of the challenge in the aspect of alcohol intake is the actual quantification. Most drinks in many parts of Africa do not contain the alcohol by volume label, so it's rather difficult to know how much a person usually takes in a day or week. How do we actually handle this? Ponciano, absolutely. I mean, often it can be difficult to know exactly the percentage alcohol in a drink, but what we would really look at is trying to establish what are they drinking. Are they drinking traditional beer, local beer? Are they taking spirits and what are they taking? And then we look in terms of volume, in terms of liters. How many is it on a daily basis? Is it binge drinking? Is it just binge drinking over weekends? Is it over, on special occasions? So we try and establish the pattern of drinking, and sort of volume, often in terms of liters, of what might be all that you can actually do if you're taking traditional beer. But I think certainly in just taking a history like that, you can still actually establish whether this is problematic drinking in terms of some US underlying chronic liver disease. So we would really try and just go into a bit more detail what their patterns of drinking are, what is the volume, and particularly if there's actually sort of dangerous patterns of drinking, such as binge drinking. So I think we've covered all the questions. Thank you, everybody, for these important interactions that we've had. And then we'll just close off with the final slides. Beth, we can go on to that. So really just to thank our speakers for their excellent presentations, really for the participants who've actually come on, and particularly for their questions. And then just to note that the recording of this program will be available within about 3 weeks after this event. And after about 3 weeks, provided the speakers' permission, we'll actually have the materials on the academic medical education website, so you can actually look at the slides. Next slide, please. So once again, thank you all for joining, and we hope to have ongoing webinars that will actually advertise during the year in terms of particularly our special interest groups, which may be of interest, such as the autoimmune hepatitis, viral hepatitis, HCC. Next slide, please. Next slide. We'd once again to acknowledge our sister societies and our endorsers. And importantly, it's important to realize that SOLDA is actually a sister society of ASLD, EASL, ALA, and APASL. And we're really very grateful for our endorsers who are multiple across the globe, and really hope to grow these interactions. Very importantly, we do need your feedback, what actually worked, what didn't work. So we ask you to participate in our post-event survey after the event, and then you'll receive a certificate of attendance by email once you've completed the post-event survey. Next slide, please. And so once again, thank you for joining us, and we hope you have a good weekend. Thanks. Bye.